Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 168th episode of the Codecast podcast. My name is Terry Fletcher. First, Happy New Year. Happy to be in 2021. Welcome to the new year and our first episode in the new year. So I wanted to just have a quick, what we call quick hits, so a brief quick hits update today about some healthcare news, realities, and myths. The reason is that over the holiday weekend, I should say last couple of weeks, I'm seeing so many social media posts, mostly on LinkedIn, but also hearing a lot of incorrect comments on the new fee schedule and a lot of confusion on some of the information that has changed and been updated and incorrect information that's been given out. But I think a lot of it also stems from the fact that a lot of times we read through our publications, and when we read through that, we don't always look at the date. And so I've noticed that some people were texting me and sending me messages over the last few days, and they're saying, you know, Terry, I was told it was this and this, and I knew exactly where they got their information. And it was an authoritative source. So it was Part B News through Decision Health. And I said, look up and tell me, is it volume 34, issue 47, dated December 14th? And they said, yes. And I'm like, well, since December 1st, when the final rule was published, we've had so many changes starting with December 28th when President Trump signed the COVID relief packet, bill, to kind of offset some things. So, and it really changed a lot of the information that we were told on the 14th. So you have to really make sure that you are updated, that you are proactive in making sure you're getting your current information. But I also want to make sure that everyone not only was accurate and current, but that they understood some of the information about maybe what you thought was happening, but was altered on December 28th. That COVID relief bill really caused some confusion, and I wanted you to know how it will affect your reimbursement as you head into the new year, because some of the temporary public health emergency things you want that you're actually billing for now or getting reimbursed for now may change as soon as the PHE ends, which is set to end January 26th. Now, just because it's set to end and the vaccine is out, I would probably guess that they're probably going to extend it one more time, but that's it. Mainly because a lot of the temporary, even when we talk about telehealth, but temporary services under the PHE waiver, 1135, it says under the public health emergency or until the end of the year in which the public health emergency ends. So if they end up basically ending the PHE, then it's still a lot of things, not everything, but a lot of things will still go to the very end of the year. But we just want to be clear on, especially when it comes to reimbursement, because we didn't get our final fee schedule conversion factor until the 25th. Actually, the 28th, I'm sorry. I'm looking at a January calendar right now, and I keep looking at the wrong date. But we just have to make sure that we're looking at the right information, what's effective. And what the biggest thing that I found happened is that we knew we were going to get a cut in the Medicare Part V conversion factor, and we knew it was going to start in 2021 and it was going to go down from 3609 in 2020 to 3241 in 2021. Well, when you start getting politicians in the mix, they start doing things that we call doublespeak, and they say, oh, the COVID relief package gave a raise in the conversion factor in the fee schedule. I'm like, well, sort of. So what it did, instead of getting a 10.2% reduction down to 32.1, we did get a 1-year fix, which is what they are calling a raise. And it was a 3.75% raise, but on the already published 2021 fee schedule. So on the conversion factor. So the 3241 was what they were talking about. They were giving a raise on that, which took it up to 3363. So the confusion, and a lot of actually people that I trust and colleagues started saying, no, it's a raise on the 2020 fee schedule. I'm like, no, it isn't. First of all, that is not going to exist as of the 1st. It's already published in the final rule that the fee schedule is 3241. So you have to stop thinking about things in terms of 2020. You have to start thinking about things in terms of what's been published for 2021. So what happened again is that the 3.75% increase to the conversion factor was on the 2021 multiplier. So that's the 3241. It went up now to 3368, which means that the 10.2% decrease that we were seeing from 2020 is actually in effect about 6.5%. So yes, we got an increase to what was budget neutralized to be a very big decrease, but we got an increase to that only for 1 year. So remember, whatever calculations you made on that 3241, that is actually going to be coming into effect in 2022 unless Congress moves mountains, because that has to be in there for budget neutrality. We have too much money going out and it'll bankrupt the system if we don't have that. And so based on just the COVID strain that's been on practices and things like that, they went ahead and did that small increase. Well, with that increase, where are they going to find that money? Okay, I know it seems like sometimes they just print it in the basement. Well, where they found that money was basically by delaying a certain code, and it's actually a HCPCS code that they were giving us, and they called it a new code for complexity on a patient. And this code was the G2211 code. Now, this was supposed to be for specialists, for physician specialists, and also they called it the primary care code pretty much. Well, this code as an add-on code was going to be about $16, give or take, as an allowable. Well, because of the 3.75% that we got to offset the terrible, new multiplier, they basically said we can save $3 billion by delaying this new complexity code until 2024. So again, if you're reading your Part B news, which is an authoritative reference, that from December 14th, it's inaccurate now. It's basically what we call dated. That's why whenever I do on-demand webinars or anything like that, people say, okay, well, we want to leave it on our website forever. I'm like, no. It's good for 120 days because things change. I mean, this changed in a matter of 10 days, 14 days, it even changed even more. So this visit complexity code, again, the HCPCS code G2211, formerly GPC1X, that was the placeholder, that is actually now been pushed or delayed until 2024. That's how they found this new money, basically the $3 billion, to be able to give us that 3.75% overall increase. Now, what didn't get pushed was the new add-on code for prolonged services for level 5. So we know that we have a new code for prolonged services that CPT put out there, but what was happening is that Medicare and CPT could not agree on this prolonged service code, and so basically they said, no, we're not going to agree on how it's applied. And so the new prolonged service code is a G2212 code. And this code actually is an additional, let's say, 15 minutes. And what's interesting about this code is that it's added on after you've met the certain amount of time that you have in the new time thresholds for E&M. Well, CPT is kind of gray in that area, and they say as soon as you meet the minimum for that service, then you can now add on their code for that, the 99417, if it's just a private commercial plan. But Medicare said, hold on, wait a minute. We don't agree that the 99417 is being used correctly. We're saying basically that it should be when the total time, so the maximum time in that visit, I should say, has reached beyond. So when it's beyond the maximum required time for the primary procedure code, then you can add on that additional 15 minutes with that G2212 code. And you can't use it on this, you can't use any other numerical prolonged service code anymore. So the prolonged service codes 99354 to 99358, those are going away as far as being able to be used with E&M services, and 359. And then 99415 and 416, those are not part of this. But the 99417, again, is for only level 5 add-on, and then G code G2212, that is the CMS created code. Now remember, when Medicare creates a G code, that means that it's a temporary stopgap because they want to track it. They want to decide if they want to actually create a permanent HCPCS code to see if it's appropriate. And so there's going to be a problem because, again, CPT says when you can add on that 99417, let's say a 99205. Well, total time required is 60 to 74 minutes. Well, on a 99215 or 205 with a G2212, you have to have 89 to 103 minutes. So it's really kind of interesting to show that, Medicare is saying one thing and CPT is saying something else. And CPT is, very specific about certain things that they're saying you can bill for and what you can't. Another one would be the 99358, for example. So that code is actually a non-face-to-face prolonged service code, but they won't allow that now in conjunction with any office visit. CMS won't, and a lot of the commercial plans are saying we're following suit. So Medicare says we may revisit the idea because we're not opposed in some point to report prolonged, office services. But for right now, we want all the related time on a given date to be accounted for. So that's why we're looking, into that. Now, another thing, and this is when we get into, again, myths versus reality, is that telehealth, yes, was expanded. But unless Congress acts, and at some point during the year, and we don't know what's going to change within the new administration, there could be some issues when it comes to place of service and that originating site. And I've alluded to that before in different podcasts. But for example, they added group psychotherapy, physiological and neuropsychological testing, domiciliary or home custodial care services, home visits. Now, everybody says, well, that doesn't even make sense. Why would home visits need to be on telehealth if the patient's already at home? These are home health agency visits. Okay, right now, the actual caregiver has to come out to the patient's home. Well, during PHE, they're temporarily allowing this to be done through telehealth. And so just know the difference on home health versus home visits because the patient actually is at home. There's a big difference there. But the biggest thing is that most of these codes will eventually go back to the old telehealth rules of having to be at an originating site, not the patient's home. And then there would be a distant site, which would be the telehealth provider. But because right now the current law states that this is only during the public health emergency that the patient can be in their home. So some things may change, but that's not one of them that's set to change. Now, another one is audio only calls. So I want to explain this one because there's a lot of confusion on this. So Medicare said that we recognize that the need for audio only interaction could remain as beneficiaries continue to try to avoid sources of potential infection. Okay, so obviously during the pandemic, such as a doctor's office, if that's the case. And in that circumstances, they feel that maybe a longer phone conversation may be needed to determine an in-person visit versus a virtual check-in, which is usually 5 to 10 minutes. Well, let me explain how this is going to work once the public health emergency ends. So CMS will stop paying separately for phone calls. Those are the 99441 to 443 codes. And what those are patients that don't have, FaceTime or basically audio and video capability, and they're based on time only, and your physician is just billing a phone call instead for their care. And basically the patient still has ongoing care. Well, and it just means that they can't come in face-to-face or they can't do a face-to-face service. So I would probably document that as well. Well, there's a new code that was just created, and it's what they call a brief communication technology-based service. It's another virtual check-in. So right now we have the G2012, which is for 5 to 10 minutes to determine if the patient needs to come in. Now we're going to have in 2021, and so it's effective now, the G2252. And this is to be used for established patients only for the remainder of PHE, and if it ends sooner, to the end of 2021. This is an 11 to 20 minute medical discussion, similar to the 99442, and they priced it that way. But basically, this is for patients that when the acuity of the patient's problem is not necessarily likely to warrant a visit. That's why they're saying it's only for established. It just means that a needs of the particular patient requires a more assessment time from the practitioner than the G2012. Remember, virtual check-ins are basically patients that don't need to come in. A phone call visit, again, we're just talking audio only, are patients that need to come in but don't have the actual capability to come in because of infection, or they're slowing the spread, or whatever reason, and the fact that they don't have FaceTime or any kind of video capability. So that's the difference between those codes, and try not to miss that. I think some people actually miss that concept on those codes. Now, the biggest thing to keep in mind is that place of service. That's going to be a really big deal when the public health emergency ends. And the phe.org is where you would continue to look and make sure if something's going to change or not change, because that's where they continue to let you know, when the public health emergency is going to end. Now, one of the things also you will see is somebody will say, well, they extended it. Well, always know that it's 90 days. So they never tell us 90 days. They just know that's what it is under the public health emergency. Okay, so my coding question today is actually dermatology. Well, it's actually for anybody, but dermatology, one of my clients is the one that asked it. And I thought, okay, time for a refresher, because this was kind of a question that made me nervous if you didn't know it. So it said, Terry, we would like to have your input and thoughts on a question regarding an NPI number. So that's the, national number, provider number that we use when we bill to Medicare. It says Dr. Smith used, and actually any payer, Dr. Smith used to see a patient at his previous hospital employer. He is now seeing patients and charging a new patient visit, and we are supplying our dermatology associate's NPI on the claim form as well as his NPI. Is this correct as long as we have our NPI listed in the middle of the claim section, as these are clean claims and they should go through as new patients, correct? Because they're considered new patients to our company. So their question was about new versus established patient. Well, so my question back was, wait a minute, this doctor has seen these patients within the last 3 years. Remember, it doesn't matter if you're looking at your 2020 CPT book or your 2021. New versus established patient says that a new patient is one who has not received any professional services from the physician or qualified healthcare professional or another physician or qualified healthcare professional of the exact same specialty or subspecialty who belongs to the same group practice in the last 3 years. Well, once another doctor joins your practice, now there's guilt by association. You're part of the same practice. Also, it doesn't say in that definition, or if you change practices, or if you're under a different NPI or tax ID number. If you've seen the patient within the past 3 years, and one of your partners also sees the patient, a new partner or an existing partner, and you're under the same specialty or subspecialty, then that is considered an established patient. It's not new. The only exception to that rule based on that question would be, let's say that doctor sold his practice to that new dermatology associates group and did not follow the patient. So now those physicians are seeing those patients and that doctor didn't come with. So now those patients, yes, would be new to the practice. But since that doctor came with, those patients are established to that practice for however long they see those practice, unless there's a 3-year gap. So don't forget that definition, or you could be asked for refunds. Okay, our coding question is brought to you today by Medical Economics, Smarter Business, Better Patient Care. Follow us for the latest news and viewpoints on primary care, specialty care, and industry happenings in the business of medicine and health IT. me.com. Check out my article in the January issue of Medical Economics. I wrote something and collaborated on leveraging the AR in a physician's practice. So hopefully that helps out. So my personal tidbit this week, yes, we are in the playoffs. I'm excited to finally get to playoff week next week. But also one of the things that has been a big, and that's for my Steelers, as you know, but one of the biggest discussions has been everybody switching to working virtually. So, a lot of practices, especially I'm in California, and I feel like we've been shut down for 10 months, minus maybe a month in between, sometime in July. But a lot of people are working remotely. And you want to make sure, now that we are past 2020, whoever does your taxes, make sure that you talk to that person and ask them about writing off a possible percentage of your dedicated workspace on your taxes. If you work for yourself, or if you're a contracted employee or a regular employee who has to shift to virtual working, you possibly may have some options on percentage of space. You can take it as an itemized write-off. So along with a percentage of your utilities, etc. Now, the rules mean that you have to have a space that's dedicated only to work. So if you're at your kitchen table, that's not going to help you. If you converted a guest room, though, into an office and you don't use it as a guest room, that could be a huge help in saving you money on your taxes. Just make sure you know it can be whether you own your home or rent it, and just ask. So I just wanted to put that out there because some of you may not have even thought about that. It's usually if you itemize, if you just do an easy form, that's not going to help you. But if you itemize your taxes, make sure you ask somebody about that. If you're working virtually, and let them know, say, hey, I have this dedicated workspace. They're going to need to know what your square footage is of what your domicile, where you live, and, talk about utilities too and all that, because you are utilizing now your home as your workspace and you should get some credits for that. So just make sure you ask. Okay, everyone, make it a great day. Again, Happy New Year, and I will talk to you next week on the Codecast podcast. Thanks for joining me.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.